Welcome to Level Up. Today's topic is hydrothermal therapy or external water treatment, and we hope you will enjoy it. I'm Dr. Leila Lewis. I'm a board-certified obstetrician and gynecologist. I'm also the medical director of AWR 360 Health. AWR 360 Health is the sponsor of Level Up, a YouTube show that brings you straight answers to your medical questions. If this is what you're looking for and you would like to know more, go to the bottom of your screen and subscribe to the channel below. We really hope you'll do this so that we can continue to communicate with you. In addition to that, you can indicate your questions and we will provide those answers as we are able in the future. Again, please subscribe to our YouTube channel. Now, a while back, at the beginning of the COVID-19 pandemic, we had a medical symposium where we explored different aspects of COVID-19 and various alternative solutions to a problem that was actually treated back in the 1918 pandemic. Well, one of those was Dr. Roger Schwelt's presentation on hydrothermal therapy or water treatment. It was such an amazing presentation and so well received. We wanted to re-show some of those parts to you. So Dr. Schwelt will be presenting this to us in the upcoming show. Dr. Schwelt is a pulmonologist. He is also an adjunct professor of medicine at the School of Loma Linda, and he's also the director of MedCram. We hope you'll enjoy this presentation.
Necessity is the mother of invention. And with this epidemic and what's going on right now, we are looking desperately for things that can help. And looking back far enough, we can find it. So that is the question. Does hydrothermal therapy work? What does the science say? You know, we are fully in pandemic mode here with COVID-19, and the deaths don't seem to be slowing down. But very early on in this pandemic, we had some good data coming out of the Lancet that showed that there was 3 phases essentially to this. There's the phase prior to infection, and then there's the part after infection. There's about a 5-day period of time where there is asymptoms, no symptoms, and then about a 7-day period of symptoms. And then some people get worse, need to go to the hospital, and from there things to go pretty bad, pretty fast. 1 day from admission to worsening shortness of breath, another day to ARDS, and then finally into the intensive care unit. And so with that in mind, let's sort of go over those phases there. We've got the population that is exposed, and then there's an infection that must occur. And we're doing isolation, social distancing at that point to interrupt this phase. And then there's phase 2. Phase 2 is when you have symptoms, you're infected, and you're not yet able to be admitted to the hospital because your symptoms are not that bad. And it seems as though the data is showing that about 20% of COVID-19 patients will fit into this category and will need to go on to hospitalization, will need a ventilator, ICU, et cetera. And it's in this phase 3 that we're doing a lot of work, of course, with randomized placebo-controlled trials on different antiviral medications, on anti-malarial medications, ventilators, ICU nurses. We're not doing a lot here in phase 2. And this is the phase where basically we're telling patients from the emergency room to go home, to self-isolate themselves, and to basically wait to see whether or not they're going to be in the 20% or in the 80%. Now, fortunately, 80% of these patients will get better on their own. They won't need health care. They won't need oxygen. And the main reason for that is the immune system. So let's talk a little bit about the immune system. The immune system is made up of 2 different parts, the innate immune system and the adaptive immune system. You get both when you're born. The innate immune system is very powerful when you are first born. This is the part of the immune system that gives you a fever. This is the part that goes around eating up particles called the PAMPs, or molecular patterns that look abnormal, and they present it to the adaptive immune system, which finds it, remembers it, keeps memory cells of it. So the adaptive immune system, the one on the right, is the one that remembers vaccines. The one on the left is the one that goes out and scavenges and looks for particles. What we're finding out is that when we give a vaccine, that vaccine is going to cause memory cells on the right in the adaptive immune system, but there's a spillover of activation in the innate immune system. And as we're going to find out here very shortly, it's the innate immune system that seems to be crippled with this COVID-19. Now, I want you to remember a couple of cells. There's the natural killer cells, which are descendants of a lymphoid progenitor. but nevertheless, it's part of the innate immune system. And then these monocytes that are part of the innate immune system. We're going to talk about that. So there was an article that was published out of a center of excellence in Thailand titled Immune Responses in COVID-19 and Potential Vaccines, Lessons Learned. And basically the point of this article was to compare the first SARS virus in 2002 with the one in 2012. That was MERS. And those are both coronaviruses. And to use the understanding of that in comparison to what's going on right now with SARS-CoV-2 and COVID-19. And in this article, they pointed out a number of interesting things. Number one, that an increase in neutrophils and a decrease in lymphocytes was very similar to the prior two infections. And this correlated with an increased chance of death. It's well known that the first SARS virus and MERS both suppress the innate immune system, and that COVID-19, the current one, may dampen antiviral IFN responses, resulting in uncontrolled viral replication. That's something that we've seen a lot of, is people just are infected for a long period of time and they just can't kill the virus and get better. So what's going on there? They definitely say that there's an issue with the innate immune system, and that it's suppressed at first and then allowed to go into overdrive, causing potentially that cytokine storm. And I think this paragraph in the article really says it. They say, based on the accumulated data for previous coronavirus infection, innate immune response plays a crucial role in protective or destructive responses and may open a window for immune intervention. SARS-CoV-2 probably induces a delayed type 1 IFN and lost viral control in an early phase of infection. Individuals susceptible to COVID-19 are those with underlying diseases, including diabetes, hypertension, and cardiovascular disease. In addition, no severe cases were reported in the young children. This was at that time, when innate immune response is highly effective. These facts strongly indicate that innate immune response is a critical factor for disease outcome. And we can see here's another paper that was published back in 2004 on the first SARS virus that notices that these natural killer cells are at a very low percentage in comparison to a regular bacterial infection. There's another paper that was published in Nature Medicine. This was recently published just last month, that took a woman who was in China infected with COVID-19 and was hospitalized in Australia. They did an essential workup on her and noted that yes, her monocytes and natural killer cells were suppressed. So what's going on exactly? This is another paper that was just published last year before COVID, and it showed that BCG vaccination, even though it targets the adaptive immune system here on the right, there is a spillover, and it seems to induce an energy into the innate immune system, allowing it to fight better. So in other words, they saw a more than normal reduction in viruses when they were given the BCG vaccine. And so that has led to a multi-nation strategy of potentially vaccinating people again to the BCG vaccine. Well, something else has come up that's very interesting. And this was a paper that was published by Dr. Ashish Kamat, who is a urologist at MD Anderson in Texas. And what they've noted is, if you look at countries here in light yellow, these are the countries that give the BCG vaccine. In these countries, the mortality rate is about 10 times less than in countries that have never gotten the BCG vaccine. Those would be countries that are in dark orange, like Canada, the United States, and notably Italy. The countries in purple are countries that used to give the BCG vaccine, but are no longer giving the BCG vaccine. So the question is what is it about this innate immune system, and what is being done about it? So of course, this is not just news to us. There are several companies that have looked at the innate immunity of the body and have targeted this for cancer research. And now that they see a much bigger issue in terms of COVID-19, they're repurposing their technology for this. And there's a company that's looking at placental mesenchymal cells to have them derive into natural killer cells to see if that can fight the fight against COVID-19. There was another company out of Israel that is doing a small trial. They tried it in 8 patients, again, using mesenchymal stromal cells from the placenta that will readily differentiate into natural killer cells. And they're finding, as it says here in this article, 100% survival rate. This was just published just a few days ago. Here's another one. This is a South Korean company that's looking at natural killer cells. So this seems to be the focus of where we are going. So in short summary on this section, I think a good working hypothesis would be that SARS-CoV-2 infection downregulates innate immunity, and that SARS-CoV-2 is allowed to progress because innate immunity is not strong enough. And that strengthening that innate immune system might be a place to stop COVID-19, especially in this very sensitive phase 2. Where not much is being done. Patients are being sent home from the hospital and asked to stay there and isolate until they get worse. Is there something that we can do in this very long stage, about 7 days, it seems like on average? Well, there's a lot that we can do, and we've got a lot of evidence for this, and we could do a number of talks about sleep. We've talked about that on our channel, and I've seen a lot of talk on the internet about that. Nutrition we haven't covered yet, but there's a lot of stuff we can do there. There's others. Dr. Nedley was talking about the sanitarium talk. Certainly hydrotherapy was going on there. They were also taking them outside in the sunlight. There's vitamin D. What I want to talk about and focus on is water. Water is a very interesting substance because out of all the substances that we have, it really holds heat the most. It has what we call a high enthalpy of heat. So what do we know about this? Well, let's go back to a German study in 2002 that I think should start us off. Let's look at the cellular biology. Here, they took about 12 healthy volunteers, and the only reason why they needed 12 is they didn't need to do much to get statistical significance. This is a pretty high activity here. They were immersed them in 39.5 degrees centigrade water. And what they noticed after that is that not only were there more monocytes, so increasing the body temperature increased the number of monocytes, but when they took those monocytes outside of their body and put them into a test tube where they subjected them to lipopolysaccharide, which basically tells the cells that there's bacteria around, they were actually more active than they were when they weren't submerged in 39.5 degrees centigrade, which tells us that not only is it's not just a parlor trick where we're just getting more cells, we're actually seeing the cells activated. And so the authors of this study concluded that the thermal effect of fever directly activates monocytes, which increases their ability to respond to bacterial challenge. Remember, monocytes are part of that very important innate immune system. And what about exposing to cold? So a lot of times in hydrothermal therapy, we will expose the person to cold after heat. This is what I'm reading. And what it does is instead of allowing the body to dissipate the heat through vasodilated peripheral vasculature, it causes vasoconstriction to lock that heat in. So here was a paper that was published at the University of Toronto, but sponsored, interestingly, by the United States military to see what would happen when people were subjected to cold after being in hot. And what they noticed is that the natural killer cells went up statistically significantly. The lytic units in the natural killer cells went up. Lymphocytes, monocytes, all of them went up. And that was your innate immune system, to the point where the authors concluded that this study suggests that despite popular beliefs that cold exposure can precipitate despite the popular belief that cold exposure can precipitate a viral infection, the innate component of the immune system is not adversely affected by a brief period of cold exposure. Indeed, the opposite seems to be the case. The fall in core body temperature resulting from cold exposure led to a consistent and statistically significant mobilization of circulating cells and an increase in natural killer cells activity and elevations in IL-6. So I think that was, again, only 7 subjects needed for this study because the effect was so profound. Here's a Polish study that looked at that. Apparently in Poland, they like to go swimming in the wintertime. So they looked at that. We just looked at a study that looked at it over just one episode. What about if we do it multiple times? So at the end of a winter swimming season, they took people who like to do this, 12 habitual winter swimmers, and they looked at 8 people that didn't do that. I can tell you that I would have been in that second category because I don't really see the need to go swimming in the wintertime. But nevertheless, in the part that went swimming in the wintertime, they had increased concentrations of leukocytes, monocytes, and plasma IL-6, and they were statistically significantly higher. And I can show you more and more studies, more than we have time for. But the question is, okay, so if we're heating people up and we're increasing the immune system, isn't that going to cause more of a cytokine storm? Isn't that going to make people worse? Maybe we'll get them into the hospital faster than shorter. Well, I think this paper that was published about 5 years ago really answers that question. And what this paper titled Fever and Thermal Regulation of Immunity, the Immune System Feels the Heat, showed was that fever actually can bring down the number of cytokines. Listen to what they say in this paragraph. Although febrile temperatures initially increase the production of pro-inflammatory cytokines by macrophages at sites of inflammation, there's also evidence that thermal stress dampens cytokine synthesis once macrophages become activated. And they go on and talk about these monocyte-derived macrophages and how they look for these PAMPs, these molecular patterns, to eat them up and present them. And it shows that the messenger RNA, which is the message that tells the cell to make the cytokines, is degraded by the fever, so you actually have less cytokines. Finally, they mention about a mouse model of collagen-induced arthritis. And they say here that mice exposed to fever-range hyperthermia had significantly less joint damage, correlating with a reduction in serum tumor necrosis factor levels and an increased IL-10 production in inflamed joints. Collectively, they say this finding suggests that strategic temperature shifts contribute to a biochemical negative feedback loop that protects tissues against damage from excessive cytokine release following infection. Okay, so let's summarize here. Working hypotheses. Innate immunity can be strengthened, at least by surrogate markers, by manipulating external heat cold applied to the body. Number two, heating and cooling seems to increase markers of innate immunity, like natural killer cells and macrophages. And number three, these interventions don't necessarily seem to exacerbate the cytokine storm implicated in ARDS or pneumonia. All right, but what about real people and real diseases? Enough with the cells. Well, for that, we've got to go back to the last century. There was a famous psychiatrist, Julius Wagner-Jauregg, who noticed in his psych wards that people with neurosyphilis got better when they had a fever. Well, at that time, they didn't have penicillin. This was well before penicillin, but they did have quinine sulfate, which was the treatment for malaria. So we had this idea, what would happen if I infected these people with malaria? Very carefully watching them, and then see if the fever treated the patient. Sure enough, it did. And in 1917, he published his first report where he actually induced an infection in a patient so he could get a fever. The fever, the increased temperature in the body, cured the patient of neurosyphilis. And then he cured the patient of the malaria with the quinine sulfate. He won the Nobel Prize for Medicine for just that. And at that time, there was many ways that they can induce a fever. Malaria was just one of them, but as you can see, they would inject people with foreign protein, chemicals, sulfur, etc. But I find the last one here the most interesting. Immersion of the individual in a hot bath or placing him in a heat cabinet. Well, Dr. Wagner-Jauregg, as Dr. Nedley mentioned, had a colleague across the country in New England. Dr. Rubel was the medical director of the New England Sanitarium, which Dr. Nedley was talking to us about. And just to review those results again, he noticed that in the sanitarii, or the sanitaria, the overall mortality was about 1.3%, as opposed to the overall in the Army camps of 6.4%. Now, this is where they were using aspirin. It had just come out in 1899. They were suppressing fevers. They were in big tents. They were all crammed in. The air was not that clean. So why was the mortality again lower in the sanitarium than it was in the Army hospital? It wasn't because they were doing a better job of treating pneumonia. No, indeed, their mortality rate for pneumonia was arguably higher than it was in the Army camp. It's because less people got pneumonia. So only 2.5% of the people in the sanitarium got pneumonia, whereas 17% of the people in the Army hospital got pneumonia. And at that time, before antibiotics, pneumonia was a bad thing to have. By the way, Dr. Rubel, what did Dr. Rubel attribute his success to? And I think it's very interesting to read the last sentence in his write-up, which was published in Life and Health, May 1st, 1919. He says, the principal merit, as far as treatment was concerned, was placed in careful nursing and hydrotherapeutic remedies. So there's many ways that you can raise a core body temperature, as we've just shown. This is an example of a sauna. Here we see the tradition in Finland go on many years. We'll talk more about Finland, but you get hot, and as soon as you get hot, you jump into a very cold pool. What we believe this does is it clamps down the peripheral vasculature, keeps the heat in higher and longer. But what about, we've talked about people and we've talked about disease. Let's talk more about people and diseases and less about cells, because that's where we really want to go. So here is a randomized prospective trial, I should say, that went on for 6 months. two groups, 25 in one group, 25 in the other group. The 25 in one group had a sauna bath similar to this 1 to 2 times a week. The control group did not. After about 3 months, there were half the number of colds in the sauna bathing group than there was in the control group. And this was statistically significant down to a p-level of less than 0.01. And it wasn't in particular 1 or 2 people. It was across the board that brought that number down. So it seems as though this was applicable across the board. Here's another study. This was 3,000 subjects, and it was only over a month. And what they asked them to do was to, instead of just showering hot, is to shower hot and then cold at the end to keep that heat in and cause vasoconstriction. And what they noticed is in the intervention group, there was a 30% reduction in sick days at work. 30% reduction in sick days at work. In other words, they got sick, but it reduced the severity of it so they didn't have to miss work. That was a prospective study. This study I find fascinating. Here was a study that was done in Finland. And for those of you who don't know, just about everybody in Finland does saunas. We'll talk about that a little bit more. This was a prospective study. It involved 2,200 men. And back in the early 80s, they did a questionnaire and they asked them very simply, do you use a sauna bath once a week, twice a week, 3 times a week, or 4 times a week? And that's pretty much the kind of question that you have to ask in Finland, because less than 1% of them don't take a sauna bath. Just about everybody does. And what they did is they followed them for about 26 years. And because it's a socialized medical system over in Finland, they were able to look for the names and find out how many times they've been hospitalized in their hospital system for pneumonia. Well, this is what they found. They found that if they reference those who only took it once or less per week and said that that was the reference, those who took it 2 to 3 times per week had a 33% less chance, was associated with a 33% less chance of getting pneumonia. Those greater than 4 or equal to 4 almost cut it in half. Now, this is an association study, but they listen to all the things that they took into consideration for confounders: body mass index, smoking history, diabetes, heart disease, asthma, bronchitis, tuberculosis, education, cholesterol, alcohol consumption, total energy intake, socioeconomic status, physical activity, C-reactive protein. Despite all of that, there was still a statistical significant difference. And let me just tell you, there is a plethora of data on this that shows that this is not just for pneumonia. It's also for cardiovascular disease. It's for dementia. All of these things are related, and you can look up the research on Finnish Saunas. So what's the working hypothesis? Heat followed by cold improves innate immunity significantly enough to reduce actual diseases, not just cell counts, such as colds from viral infections, as we saw, severity of illnesses, and even pneumonias requiring hospitalization, and many more studies as we've talked about. However, we still haven't talked about COVID-19, which is why we're all here. And it's really difficult to do that because we have to do studies in the current environment. We didn't have COVID-19 before November and December of last year. So let's go back to Finland and saunas. So a little bit more information, because let me be clear, saunas are not the only way you can induce to have high core temperature elevated. There's many ways. But this lends itself as such an interesting example that it needs to be pursued, I believe. There's about 5.5 million people in Finland. There's about 3.3 million saunas in Finland. And as you can see with a regular sauna, you can get a lot more than 2 or 3 people. To the point that if you asked all the people in Finland to go into a sauna all at the same time, they could actually do it. And it would hold the entire country. Greater than 99% of the population of Finland has a sauna bath at least once per week. Now, while saunas are very popular in Germany and Austria and Sweden and Norway, not nearly as close as they are in Finland. So that gives us a very interesting opportunity. We can go and look at the numbers. And so there's a website called Worldometer, and you can look at the number of cases, total deaths, total cases per population, million, total everything. You can look at everything and break it down. So we've done that. And I find it very interesting here that on a population level, if we look at the United States here in terms of population, cases, deaths, cases per million, deaths per million, and when the first case came, and what the University of Washington modeling says will be the peak number of deaths per day when we do get to our peak, you can see here that when we compare Finland to other Nordic countries, very similar to it in culture and in healthcare systems, we can see here that the number of cases in Finland are less than half. In number of cases of deaths, almost an order of magnitude less. The number of cases per million, less than half. The number of deaths, way less. And that is despite the fact that Finland was the first country out of those Nordic countries to have a COVID-19 positive case. If we look at the restrictions that are going on there, they have their schools closed just like Norway has the schools closed. And there's non-essential stores that are closed essentially with this. And if we look at testing, the amount of testing going on in Finland per million is not that different than what's going on here in the United States. So we have looked at the evidence for hydrotherapy in terms of COVID-19 from a cellular level, biochemical level, and we have looked at it from individuals with diverse diseases. We're talking about colds, flus, viruses, illnesses, pneumonia. And we've looked at it in a sense as a surrogate, and really now there's a lot of confounders with the population data, but we have looked at it in real time, because if this should have worked, we would have expected it to work for Finland because they're so dogmatic and religious about doing their hydrotherapy. So I think that's a really interesting statement. And where we are right now is we have to remember something, that the good is not the enemy of the perfect. There is no FDA-approved medication or treatment for COVID-19. There are many therapeutics that are being looked at, and some are very promising. So we've got to look at this good versus perfect. I mean, look at the CDC website. If you don't have personal protective equipment, they're actually recommending that you use a bandana or a scarf. That's because, well, what else do we have? We don't have studies on bandanas and scarves, but we got to do the best that we have with what we have. Keep in mind that if we come up with a medication that works beautifully and perfectly, how are we going to scale up that amount of medication that fast at this point in time? The day that it was announced that hydroxychloroquine was going to be a good medication and promising, you couldn't get it in the pharmacies. And so we have to take things with some understanding. Physicians right now, and I'm on the front lines as well, I've been treating patients last week with COVID-19. We don't have all of the answers, we don't have all the evidence, but we have to use what we've been given. And that's the definition of compassionate use. So we'll finish up with this slide. And I want to keep in mind, we've got phase 1 to prevent infection. That's social isolation, that's distancing. We have phase 2, and there's millions of people in phase 2. What are we going to do with all of the people in phase 2? That could be helpful. And then we've got phase 3. This is where we have hospitalization, ventilators, randomized placebo-controlled trials, medications to try to prevent the patient from dying.